Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome everyone to this presentation on managing patients whose blood is therapeutically anticoagulated. This video is in continuation of our previous video about hematologic problems. We will cover why it is important to understand this condition and the key precautions and treatment necessary for safe and effective dental care. Today, we will cover different aspects involving patients on various anticoagulant therapies, including aspirin, warfarin, and heparin. Our goal is to understand the best practices for safely managing surgical procedures in these patients. Patients may be on anticoagulant therapy for various reasons, including having devices like prosthetic heart valves, cardiovascular problems like atrial fibrillation or myocardial infarction, a history of hypercoagulable states, or a need for procedures like hemodialysis. Some may also take antiplatelet drugs like aspirin for secondary prevention. When electro-oral surgery is necessary, the need for continuous anticoagulation must be weighed against the need for hemostasis. This decision should be made with the primary care physicians. Low dose aspirin usually does not need to be stopped for routine surgery. For the patients on heparin, surgery can often be delayed until the heparin is inactive. In emergency, protamine sulfate can reverse heparin's effect. For patients on warfarin, it is important to work closely with their physician. The typical therapeutic INR range is 2 to 3. Warfarin should be stopped 2 to 3 days before surgery if needed. On the day of surgery, check the INR. If it is between 2 to 3, surgery can proceed with proper measures. If INR is above 3, surgery should be delayed. After surgery, use thrombogenic substances on wounds and resume warfarin the same day. If the patient's physician believes it is unsafe to reduce the prothrombin time, the patient may need to be hospitalized for the conversion from the warfarin to heparin during the perioperative period. Heparin has a shorter half-life, making it easier to manage around the time of the surgery. Direct and indirect XA inhibitors are newer anticoagulants that don't require routine laboratory monitoring. They generally have a shorter half-life, so stopping them is easier if needed. However, they typically don't need to be stopped before routine oral surgery. Stopping anticoagulant or antiplatelet medication should not be taken lightly. Most routine oral surgeries can control bleeding with proper hemostatic techniques. However, after any surgery, the body's natural inflammatory response can increase the risk of clot formation, which can lead to serious complications like stroke, pulmonary embolism, or myocardial infarction. Now, we will go through the guidelines for management of a patient whose blood is therapeutically anticoagulated. This box details the steps for managing patients on anticoagulants. These guidelines are divided into 3 sections. One is patient receiving aspirin or other platelet inhibiting drugs. Second is patient receiving warfarin, and the third is patients receiving heparin. We will discuss each section one by one. That will be the revision of the previous slides. The first step is to consult the patient's primary care physician to evaluate the safety of discontinuing the anticoagulant medication temporarily. If the physician considers it's unsafe, the patient may need to be hospitalized for a temporary switch from the warfarin to heparin during the perioperative period. Surgery should be deferred until the patient has stopped taking platelet inhibiting drugs for at least 5 days. Extra measures must be taken during and after surgery to help promote clot formation and retention, ensuring the patient's safety. If there is no bleeding present the day after surgery, the patient's anticoagulant therapy can be restarted. This step is crucial to prevent complications from prolonged discontinuation of the medication. For patients on warfarin, it is essential to consult the patient's physician to determine the safety of allowing the prothrombin time to fall to 2 to 3 INR. This process may take a few days. Also obtain the baseline PT to guide further steps. If the PT is less than 3.1 INR, proceed with the surgery and skip to step 6. If the PT is more than 3 INR, you need to follow the next step to reduce the PT. Stop warfarin approximately 2 days before surgery. Check the PT daily and proceed with surgery when the PT falls to 3 INR. Take extra measures during and after surgery to help promote clot formation and retention. Restart warfarin on the day of surgery to prevent prolonged discontinuation and associated risks. For patients on heparin, first consult the patient's physician to determine the safety of stopping heparin for the perioperative period. Restart heparin once a good clot has formed to ensure patient safety and effective anticoagulation management. To summarize, managing dental patients on anticoagulants involves understanding their medical history, conducting necessary laboratory tests, collaborating with healthcare professionals, and planning surgeries carefully. Patient education on post-operative care is also crucial for successful outcomes. Always consult with the patient's physician when dealing with anticoagulant therapy. Defer surgery and follow specific guidelines for each type of anticoagulant to ensure patient safety. Restart anticoagulant therapy as appropriate after surgery to prevent complications. Thank you. Wish you best of luck.